My name is Nushin Yamani. I am a neurologist and headache specialist from Iran. In this video, I am going to talk about one of the most challenging type of headache disorders, which is called new daily persistent headache. Let's start by a short presentation of a patient. Sarah is a 34 years old woman without a significant past medical history, presented with persistent headache which was of acute onset and occurred daily from 8 months ago. Her persistent daily headache was typically of moderate intensity and was localized to the right occipital region. There was never any pain-free time, and she intermittently experienced associated symptoms including nausea and photophobia. She never experienced any triggering factor and could not identify any precipitating event prior to the onset of her headache. Her neurologic examination and neuroimaging evaluation were normal. Prior therapies before coming to the headache clinic included near daily analgesics, which were minimally effective, topiramate, which lowered daily headache intensity but did not provide any pain-free time, and oral prednisone, which reduced but did not eliminate her headache. Sarah was given the diagnosis of new daily persistent headache as she met the International Classification of Headache Disorders criteria for NDPH diagnosis. According to the ICHD-3 classification, headache should fulfill these criteria to be diagnosed as new daily persistent headache. Headache should be persistent, fulfilling criteria B and C. Criteria B is distinct and clearly remembered onset, with pain becoming continuous and unremitting within 24 hours. And criteria C is persistence for more than 3 months. And like other diagnoses according to the ICHD-3 criteria, headache should not be better accounted for by another ICHD-3 diagnosis. NDPH is thought to be a rare disorder. The prevalence rate has been estimated at 0.03 to 0.1% in the general population, and it's higher in children and adolescents than in adults. The prevalence might be higher in women than in men. NDPH typically presents with sudden onset headache, which starts one day and continues without remitting within 24 hours. It is mostly bilateral in location and can occur anywhere in the head, with mild to severe, mostly moderate intensity. The pain is constant and lacks special characteristics and could have characteristic features of either migraine or tension type headache, or both. NDPH typically occurs in individuals without prior history of headache, but patients with prior episodic headache are not excluded from NDPH diagnosis if they do not describe increased headache frequency before the onset of NDPH or exacerbation of headache associated with overuse of medication. The majority of patients can pinpoint the exact date their headache started. Triggers are noted in less than 50% of patients, with infections being the most, while others describe stressful life event, trauma, and surgery as triggers. The exact pathogenic mechanism of NDPH is still unknown. However, pro-inflammatory cytokines and cervicogenic problems might play a role in its development. The diagnosis of NDPH is mainly clinical and based on typical history and the ICHD-3 diagnosis and exclusion of secondary causes of headache. The neurologic and general examination and neuroimaging evaluation are usually unremarkable. However, proper neuroimaging and laboratory investigation are warranted to exclude secondary causes of headache mimicking NDPH, particularly cerebral venous sinus thrombosis and spontaneous CSF leak. It is now well recognized that NDPH usually presents as one of the most treatment refractory primary headache disorders and can be highly disabling to the patient. And a specific well-defined strategy for treatment of NDPH based on clinical evidence is lacking. So how can we help patients with NDPH by treating them properly? It is probably best to treat NDPH based upon the predominant headache phenotype, whether migrainous or tension type headache. For patients who do not respond to common prophylactic drugs, intravenous lidocaine, intravenous methylprednisolone, ketamine infusion, monobotulinum toxin type A injection, and nerve blockade are possible treatment options. However, in many patients, even aggressive treatments are ineffective or only partially effective, and NDPH patients might start to overuse medication. Thank you for your attention, and if you would like to read more about NDPH, you can take a look at our review article published by the Journal of Headache and Pain on this enigmatic disorder.